first thing we're doing in sitting position is we're going to repeat a few of the things that we did in standing, just simply to see if there's been any change now that the feet are no longer in contact with the ground. This can be important in seeing some functional differences to see what effect the legs have. If everything's the same, that indicates that perhaps there is some dysfunction actually in this area, versus if they're changed from when we're in a standing position, it may indicate that there's something in the lower extremities we need to deal with more closely. So we'll first look at the observation to see if anything has changed, which in this case obviously there hasn't. I'll also ask the patient just to have Travis pop his hands over his chest again. We'll repeat rotation, again just looking at the general range of motion with overpressure and some resistance, and overpressure and some resistance, and back to the middle. We'll have him repeat the side flexion in the same position with the hands. Same position with the hands. Same position with the hands. Overpressure and resistance. And then to the other side. Overpressure and resistance. To the middle. We can have flexion from the lower lumbar spine, which is a slump. So, from there. And then extension by sitting up as straight as possible through the lower lumbar spine. That gives us the movement from below upwards, rather than in standing where we went from above downwards. We can also then apply a compression, looking for reproduction of pain, or again, that buckling position in the sitting position. We can then also do, if I have Travis just change his hand position slightly, we can do a gentle traction, again looking for relieving of pain or even reproduction of pain. A general traction through the lower lumbar spine. Relax. We'll then change to some portions of the neurological and the dural examination. In this case, the first thing I'm going to do is just ask Travis just to extend his knee. I can then add some dorsiflexion. This is a modified straight leg raise that we can match up with the results that we get in the sitting in the supine position. If the patient is extremely comfortable now, he's not irritable, he's not in significant pain, and we think we can perform the test, we can also do a slump test. The slump test will be where the patient pops his hands behind his back and just rests them there gently in this manner. And what we'll ask the patient to do is just to slump from the lumbar spine. And we want to make sure that the sacrum stays vertical and does not go into too much of a flexion. The head will stay up, and then the patient will extend the knee and then add dorsiflexion. And we're looking for reproduction of pain, paresthesia, or a significantly different end feel. I can then have the patient lift the head, and we'll see if there's any change in those symptoms. We'll then relax everything and come to the other side, extend the left knee, add dorsiflexion, head down, and then raise the head, see if there's any change, and relax. That is the basic slump test at this point in the examination. We'll then allow the patient just to relax into a normal sitting position. We'll do a deep tendon reflex on the quad D patella tendon, looking for reflex activity. These would classify as brisk, okay. Not hyperreflexive, hyperreflexive. They would tend to bounce back 3 or 4 times with that. We can try it again 2 or 3 times to see if they actually fatigue. Travis reflexes are staying pretty healthy there. They were very symmetrical, so that also decreases any concerns we have about an abnormal reflex. You can also slightly dorsiflex and do a plantar reflex, and we get a very nice plantar flexion response there. Switch to the other side, and we get a very nice plantar flexion response there. We can also, in this position, do a clonus test, which is applied by just getting a rapid dorsiflexion in this position. And Travis actually has 1 beat of clonus there, which is well within the normal range. And by a beat of clonus, what happens is when I do that, he gives me a rapid resistance back against my movement and gives me a dorsiflexion plantar flexion movement. In an abnormal case, this would continue happening for a long period of time. We can also in this position test the Babinski. This is done by grabbing a reflex hammer or a relatively blunt object along from the heel, along the outside of the foot, up towards the big toe. An abnormal response would see the big toe going straight upwards and displaying of the 4 small toes. And that completes the portion of the examination in sitting.